Hi everyone, my name is Kiran and I'm a practicum student at For a Safer Space. I'm starting my second year in my Master of Social Work at the University of Toronto, and I will be presenting on A Therapist's Guide to Brief Cognitive Behavioral Therapy written by Jeffrey Cully and Andra Teaton. So the first module is Introduction to Brief Cognitive Behavioral Therapy. Cognitive behavioral therapy. So this therapy targets emotions by changing thoughts and behaviors that are contributing to distressing emotions. CBT, it helps identify how situations, thoughts, and behaviors influence emotions. It improves feelings by changing dysfunctional thoughts and behaviors. And it is a collaborative process that includes skill acquisition and homework. So brief cognitive behavioral therapy, on the other hand, bCBT is the compression of CBT material into 4 to 8 sessions, and it concentrates on specific treatments for a limited number of problems and is particularly useful for anxiety and depressive disorders, as well as problems that target specific symptoms or lifestyle changes. And is also useful for patients with anxiety and depression associated with a medical condition, such as diet, exercise, and medication compliance. bCBT may not be suitable for Axis 2 disorders, such as borderline personality disorder or antisocial personality disorder, and patients exhibiting comorbid conditions, as well as the presence of a second issue can impede progress. It's not also may not be suitable for those with alcohol dependence, paranoid personality disorder, chronic PTSD, and somatoform disorder. General therapist skills and abilities required for bCBT include the capability to establish a strong working relationship quickly, thorough knowledge of the treatments used, being able to structure sessions and homework material to address all problems, and being able to present material clearly and concisely with specific examples for each of the patient's issues, and the ability to be assertive, directive, non-judgmental, and collaborative. So some things to consider in evaluating patients for bCBT, whether they have a strong motivation to change. So patients that have positive treatment expectancies and patients that have clear goals for treatment, time commitment as well. And if the patient is willing to devote the time needed, including homework assignments. Life stressors, because too many life stressors might lead to unfocused work within the therapy sessions, and cognitive functioning and education level, as well as severity of psychopathology. So module 2 is centers using supervision. Supervision fosters the supervisee's development, and it ensures patient welfare and safety by monitoring patient care. It provides therapist performance feedback, allows the supervisee to explore applications and therapeutic principles. It ensures that therapists are doing no harm and possessing sufficient skills. Supervision should occur on a regular basis. Most common forms include verbal reports, process notes, audio and videotaping, and group supervision. So for selecting a supervisor, supervisor should have CBT knowledge and practice experience. Supervisor should be available for weekly or bi-weekly meetings that can involve anywhere from 30 to 60 minutes. And the supervisor should have experience with the patient population similar to those that the therapist is serving. For module 3, non-specific factors in psychotherapy. So non-specific factors refer to the relationship components of therapy, such as rapport, installation of hope, collaboration, and trust. And these factors serve as a foundation for patient improvement, and they're very critical in the early stages as they aid in engaging and retaining patients. 3 important factors in developing a strong therapeutic relationship include empathy, genuineness, and positive regard. So empathy means validating the patient's experiences. It facilitates trust and mutual respect between the patient and the therapist. There's also multicultural empathy, which involves understanding a person from other life backgrounds. So taking into account their ethnicity, socioeconomic status, age, cohort, and gender, and more. Empathy also includes validating responses, which are statements of understanding for the patient's viewpoint. Genuineness is the ability to be authentic, and it allows the patient to view the therapist as a human being. This includes supportive nonverbal behaviors such as eye contact, nodding, full attention, and it also includes role behavior in which the patient is an active and empowered being, which implies a partnership between the patient and therapist and facilitates more of a collaborative process. It also includes congruence, which is a therapist's words, nonverbal behavior, and feelings. And they should be matching each other to give the best human experience for the patient. And lastly, genuineness also includes spontaneity, which are responses and feedback provided in the moment. And these are more valuable than feedback provided at a later time as well. Positive regard is showing patients the respect that they deserve, and it allows for patients to feel more connected to the therapist and the therapeutic process as well. It is important to share any negative feelings or beliefs about a patient with a supervisor or consultant in order to facilitate positive regard. And this of course involves having an awareness as well of on the therapist's part. And it also includes commitment, which means being on time, avoiding canceling the patient's appointments, and using all efforts to help the patient. It also includes having a non-judgmental attitude and displaying warmth, which can happen in the tone of voice, facial expressions, and body postures. Active listening is also very important for the therapeutic process as well. And it's made up of 3 steps. The first being receiving the message, then processing it, and then sending it back. Therapists should attempt to remain open to all verbal and nonverbal cues. Within active listening, there's also clarification, which can simplify a message or help confirm the accuracy of what the therapist understood. So, this means asking for clarification on what a patient might have shared. It also includes paraphrasing and reflection, which means restating the patient's main thoughts in a different way or reflecting back the emotions that the patient is experiencing to gain more depth or clarification. Active listening also includes listening for themes and summary statements as well. Module 4, Case Conceptualization and Treatment Planning. So case conceptualization is a framework that's used to understand the patient and their current problems. It informs treatment and intervention techniques, and it serves as a foundation to assess patient change and progress. Case conceptualization also aids in establishing rapport, and it can provide a sense of hope for patients. In terms of when case conceptualization should take place, so an assessment of the difficulties and the creation of a problem list should occur during the very first session. And a treatment plan also should be addressed quite early, such as in sessions 1 and 2. And treatment plans should be routinely revisited to ensure that patient is improving and agrees with the flow of the therapeutic work. There's a few steps in case conceptualization. So within step 1, assessing patient concerns and difficulties. One part of this is using established self-report symptom inventories, and these can include the Beck Depression Inventory, Patient Health Questionnaire, Beck Anxiety Inventory, or State Trait Anxiety Inventory. And these are often completed by patients in the waiting room and then evaluated by the clinician during the session. And these can all provide insight into the way the patient is thinking and behaving, and it can highlight any other needs that they might have as well. A second thing that can be done in this step is problem lists. So these are useful for identifying psychological, social, occupational, and even financial difficulties. Problem lists generally contain a list of 5 to 10 difficulties from the patient during the first part of session 1. And problems are best identified using open-ended questions, and they're best described in terms of symptom frequency, intensity, and functional impact. Another part of this step can be assessing cognitions. So this is helpful to examine the patient's, it's helpful to examine the patient's thoughts, especially as they are perceived by the patient themselves. And it includes assessing how the patient perceives themselves, others, and the future. Another part of this step can include assessing behaviors and precipitating situations. Precipitating situations are events, behaviors, thoughts, or emotions that activate, trigger, or compound patient difficulties. And it includes the ABC model, which is the antecedents, behavior, and consequences model. So this model recognizes behaviors as largely determined by antecedents, which are events that precede behavior, thoughts, and mood, and consequences, which are events that follow the behavior, thoughts, and mood. So antecedents are events that occur before a behavior, and they typically elicit emotional and physiological responses. They may be affective, meaning that they may be an emotion. They can be somatic, which is a physiological response, behavioral, which can include an act, or they can be cognitive, which includes a thought. So they are subject to contextual and relational factors, and they can both increase or decrease a behavior. And the B part of the ABC model is behaviors. So these are anything that the patient does, feels, or thinks immediately following an antecedent. And these can include an affective component, which are feelings or moods, a somatic component, including bodily sensations, a behavioral component, meaning what a patient does or doesn't do, and a cognitive component, including thoughts or beliefs. The last thing in the ABC model is consequences. So these can either be positive or negative, and positive consequences increase the chances that a behavior will be repeated, while negative consequences decrease the occurrence of a behavior. And it's important to explore all components of each consequence as well. In terms of identifying consequences, short-term consequences are often behavioral reinforcers, and long-term consequences are often negative outcomes. Understanding positive and negative consequences of a behavior can help design the timing and nature of intervention for a patient. For example, treating a negative mood would decrease the need for escape through substance use. This example in particular can apply for those struggling with addiction. Step 2 in this process is clinical hypotheses and treatment plan. This includes establishing focused clinical hypotheses based on the information obtained in step 1. And this allows for direct intervention options and treatment techniques. And sharing these clinical hypotheses with the patient can improve trust and communication as well between the patient and the therapist. And the end result should include a formation of a treatment plan, which is an agreed upon strategy that gives direction to the therapeutic process. And treatment plan should include a presentation of the causes of the patient's current difficulties and a specific plan. And patient and their feedback should also be actively included and incorporated into the plan so that more of a collaborative process can take place as well. Step 3 is identifying possible treatment obstacles. And in order to identify potential obstacles to treatment, it's the best if it's done as early on as possible so that any setbacks can be avoided. Feedback from the patient is very important as well, as it allows for, again, a collaborative and active treatment approach. There may be barriers that can influence obstacles. Barriers may include logistic difficulties such as financial and travel, personal beliefs such as concerns about stigma, effectiveness of treatment, or even interpersonal issues such as a client's family may not be supportive of therapy. Module 5, orienting the patient to brief CBT. So orienting the patient to bCBT includes firstly a discussion of the theories underlying bCBT and a description of how presenting problems can be conceptualized and treated within this approach. This also includes explaining the structure, format, and expectations of therapy, and a discussion of the focused and time-limited nature of the therapy as well is very important, as well as the therapist's rationale for selecting bCBT. This should also occur in the first session and can be revisited throughout treatment. So the cognitive model is a theoretical paradigm for explaining how thoughts, feelings, and behaviors are associated. The cognitive model also suggests that thoughts about situations give rise to emotions, and that the mood can be improved and improves mood and changes behavior by modifying the way a patient thinks about situations. The behavioral aspect of CBT addresses how behaviors influence mood, including how the therapist works with a patient to increase behaviors that improve mood and reduce behaviors that decrease mood. Avoidance and escape are also learned behavioral patterns that are often targeted in CBT as well. So in the initial session, it's important to review all the intake information in order to form an initial conceptualization and formulation of a therapeutic plan. It's important to assess the patient's suicidality as well. If suicidality seems high, then crisis intervention should be prioritized. It is also important to negotiate the time that the patient will need in therapy, and diagnosis should be described in terms of cognitive and behavioral symptoms to clarify how CBT will directly address problems. Feedback is also very important as well to receive from the patient. Questions that can elicit feedback include, what did you think about our session today? Did we leave out anything you think is important to discuss? Do you feel that you have at least a basic understanding of CBT? This can strengthen the rapport and trust within the therapeutic relationship. And it also indicates to the patient that they are an active member of the therapeutic process, which again facilitates a more collaborative approach between the patient and the therapist. And it also provides a space to resolve any misunderstandings that may have occurred in the session. Module 6, goal setting. So goal setting is also includes a collaborative approach in which both patient and therapist identify specific therapeutic outcomes for treatment. So goals must be observable, measurable, and achievable, and relate to cognitive or behavioral changes relevant to the patient's presenting problem. Goal setting increases the continuity of sessions as well and allows for more directed, focused treatment and enables the patient and therapist to assess the progress of therapy. Goal setting can also include a graded approach in which small steps can be taken to reach the larger goal each week. through session content and or homework assignments. It's also important to operationalize goals, which means defining the goal and all the steps to achieve it in concrete and measurable cognitive or behavioral terms. Goal setting is also critical. It's also critical to assess the patient's situation and attitudes about the goal that they have set. It's important to ask if there's any aspects of the patient's life that may facilitate or inhibit the goal. It is also important to explore barriers and discuss strategies to maximize the chance of goal attainment. And it can also be helpful to ask patients to rate the importance of the goal on a scale of 0 to 100. If the goal rating is lower than 60, then it may be important to refine goals to increase their meaning for the patient. Troubleshooting goal setting. So goals may need modification if symptoms are worsening or if there seems to be no change at all. And if there's patient failure in completing homework and if the patient is not benefiting from the treatment itself. Therefore, it's important to revisit goals and ask for feedback from the patient about the progress of therapy. Goal revision should not imply that patient has failed, especially for patients that might struggle with perfectionism. So for them, it's important to normalize the difficulty of making changes when experiencing symptoms of depression or anxiety. And it's also important to discuss any changes in context, such as relationships, work, sleep, medication, compliance, physical health, if symptoms are still worsening, as context may have influence on the goals themselves as well. Module 7, agenda setting. So agenda setting is a collaborative process in which the therapist and patient both decide how session time will be spent. Both patient and therapist can offer items to discuss and then decide the order of the items and the amount of time they will spend on each. This can ensure that time is well spent and that both therapist and patient have input into session content. It's especially helpful if agenda setting takes place within the first 10 minutes of every session. And if a patient doesn't offer an agenda item, it can be helpful for the therapist to introduce an item or even refer back to treatment goals. And it's also important to check to see if the patient is okay with this as well. So a typical session outline can include, in the first 5 minutes, briefly reviewing the patient's mood and or physical functioning. And then in the next 5 minutes, a conversation around bridging the gap between previous sessions with the current session can take place. And then in the next 5 minutes, setting the agenda for the current session and prioritizing items to discuss. And then within the next 5 to 10 minutes, it can be helpful to review any homework given in the previous sessions, including any feedback. And then 20 to 25 minutes can include the actual discussion of agenda items and setting up homework. And then in the last 5 minutes, the current session can be summarized and there can be an exchange of feedback. Module 8, homework. So homework can include readings, behavior monitoring, and practicing new skills. Homework facilitates patients' skill acquisition, treatment compliance, and symptom reduction by integrating concepts learned in sessions into daily life. Homework can be assigned throughout treatment, and it's also important to take the patient's reading ability, cognitive functioning, level of distress, and motivation into consideration as well. It's also important for the therapist to be open to patient feedback about assignments and give reasons for each task, as well as personalized homework assignments for each patient themselves. Bibliotherapy is another method that can be used as homework, which includes assigning the patient reading materials that are relevant to bCBT. These can allow the patient to read about their symptoms and CBT itself between sessions. Bibliotherapy can emphasize the self-management focus of CBT, and it can accelerate therapeutic progress and maintenance of changes. This can include websites, book chapters, or sections of CBT patient manuals. Homework troubleshooting. It's also important to explore any reasons for not doing homework in a more proactive and non-judgmental way. Patients can be encouraged to use a calendar in order to schedule time to do homework in a more useful and productive way. And this can also provide an opportunity for time management skill building. Some homework assignments may also need to be broken down into smaller steps for some patients. And the word homework itself can also deter patients from leaning into it. So if they dislike the word homework, the therapist can work with a patient to select another label, such as practice, between session progress, task, or experiment. Module 9, identifying maladaptive thoughts and beliefs. So there's 3 layers of cognitive dysfunction, and there's a little graph here that sort of visualizes them more. So in the middle, you have core belief, and then moving outwards, there's intermediate beliefs, and then automatic thoughts. Usually automatic thoughts are the ones that come first, and then the intermediate belief, and then there's also the core beliefs that patients have. So automatic thoughts is our brief stream of thought about ourselves and others, and they largely apply to specific situations and or events and occur quickly throughout the day. We can often be unaware of these thoughts, but the emotions that they're associated with are very familiar. Maladaptive automatic thoughts are distorted reflections of a situation, which are often accepted as true by patients. Automatic thoughts also include real-time manifestations of dysfunctional beliefs about the self, the world, and the future, and these are often triggered by situations or exaggerated by states such as anxiety or depression. Next, we have intermediate beliefs, which are attitudes or rules that a person follows in their life that typically apply across situations. So this is different from automatic thoughts, which are not situation specific. Intermediate beliefs can often be stated as conditional rules. For example, if I am thin, then I will be loved by others. And these are created by categorizing the information that is received from the world around an individual. And intermediate beliefs often guide thoughts and influence behaviors. Dysfunctional core beliefs. So these drive dysfunctional rules and automatic thoughts. And the core beliefs are often formed in childhood and solidified over time as a result of one's perceptions of experiences. And because individuals with psychological disorders tend to store information consistent with negative beliefs, but they ignore evidence that contradicts them, core beliefs tend to be very rigid and pervasive. Individuals tend to have core beliefs that involve either interpersonal or achievement issues. So for interpersonal issues, that would be, for example, I'm unlovable, and for achievement issues, it could be I'm incompetent. Maladaptive thoughts and bCBT. So for the first step in the cognitive component of therapy is identifying maladaptive automatic thoughts. And in order to grasp the concept and techniques for challenging beliefs, patients must also learn to identify and challenge thoughts. An intervention targeting automatic thoughts may also change underlying beliefs. Patients should constantly be forming hypotheses about what beliefs may be driving their thoughts as well. Hot thoughts are automatic thoughts that occur in combination with a change in emotion or mood and are often associated with dysfunctional core beliefs. There may be different ways of identifying hot thoughts, including verbal cues, which is specific language that's used in the thought. Um, and this can help identify exactly which thoughts are hot and which aren't. Nonverbal cues can help with this as well, which includes increased volume of speech, fidgeting, changes in facial expression, shifts in position, or hand movements. And it's important to bring this to the patient's attention and assist them in identifying an automatic thought associated with the shift in emotion. A question that can help with this is, for example, you're speaking more loudly. What is going through your mind right now? So this includes pointing out the cue and then directly asking the patient what is happening for them in that moment. It's also important to decide which automatic thought to focus on. And it's best to focus on the automatic thoughts that are most likely to bring the greatest change. And the therapist can help the patient choose which automatic thoughts to focus on by referring back to the goals for the session and therapy, as well as the agenda items. Automatic thoughts can also be quantified using a scale of 0 to 100 based on how intense the associated feeling is. It's also important to identify cognitive distortions, which are thinking errors. And these can also aid in choosing a hot thought, case conceptualization, and treatment planning. Intermediate beliefs. These can be identified by listening for themes in the patient's thoughts and behaviors. It's also important to ask the patient directly about their beliefs and to identify a theme. The therapist can have the patient complete a questionnaire or inventory as well that can help identify their beliefs. An example of this could be the dysfunctional attitude scale. And core beliefs. So hypothesizing core beliefs that may be underlying dysfunctional behaviors and thoughts can help with case conceptualization and the treatment plan as well. A core belief will usually appear in several areas of the patient's life, including their relationships, their work, their parenting, and more. An example of approaching core beliefs when speaking to a patient can be something like, I've heard you say several times that you either didn't do a good job or that someone else put in more time and energy. It seems to me that you feel inadequate a lot of the time. Is that right? So this can sort of bring more awareness to the core beliefs and allow the patient to sort of like analyze their own personal perception of the core beliefs as well. And a discussion of childhood experiences can be helpful as well because they may help identify the possible origin of the core belief. And lastly, it's important for the patient to know that core beliefs are only ideas and that feeling them strongly does not make them true. Module 10, challenging maladaptive thoughts and beliefs. In order to challenge these thoughts, a method called Socratic questioning can be very helpful, in which includes a therapist's stance for questioning maladaptive thoughts and behaviors and involves asking open-ended and brief questions that guide the patient to discover thoughts, feelings, or behaviors associated with a particular situation. And questions are designed to expose a dysfunctional thought or belief so that it may be challenged. Another thing that can be beneficial is a dysfunctional thought record, which is used to challenge dysfunctional thoughts and beliefs as well. And this includes the situation, thought, feeling triangle, which includes which makes up the first three columns of the DTR. And it's important to identify any cognitive distortions and thoughts as well. The patient can elicit and rate emotions associated with the hot thought, and then they can rate the believability of hot thought based on any evidence, which is the next step. So generating evidence for and against the hot thought, and then generating alternative thoughts to form thoughts from the evidence itself. And then the patient can rate believability of alternative thought. And lastly, re-rate emotion of hot thought that is elicited by alternative thought. Developing balanced thinking can also be a very helpful intervention, which includes helping the patient question their automatic thoughts. For example, the therapist can ask the patient, what evidence is there that this thought is true? What evidence is there that this thought is not true? If my automatic thought is true, what is the worst that could happen? And what is the best thing that could happen? And then once evidence has been generated, it can be combined to form a more balanced thought. For example, the question can be, is there an alternative way of thinking about the situation? Next, the patient can rate the believability of the alternative thought between 0 to 100. And if the thought is not more than 50 believable, more work may be needed to identify an alternative thought so that the patient can have so that the patient is able to actually believe the thought and hold meaning to it. And then lastly, re-rating the mood that's associated with the hot thought after generating the believable alternative thought. And essentially a reduction of 30 to 50 in the rating is often best to provide relief. Module 11, behavioral activation. So behavioral activation is a set of procedures and techniques that increase patient activity and access to reinforcing situations that improve mood and functioning. And behavioral activation can improve mood by reversing avoidance, increasing physical activity, increasing self-confidence, and also increasing feelings of usefulness and purpose. Behavioral activation can include reintroducing prior pleasant activities, introducing new pleasant activities, as well as active coping, which means taking some form of behavioral action to reduce a life stressor. A few steps can be included in behavioral activation. The first step can be providing the patient with the rationale for behavioral activation, because it's important for the patient to sort of understand the connection between what they do and how they feel, both mentally and physically. It can be helpful to explain that increasing activity and or taking action, even when we do not feel like it, can help one feel better physically and decrease depression. And if a patient with depression increases their activities on a daily basis, it can improve mood and decrease symptoms. Step 2 includes identifying behaviors, so discussing activities. Some questions that can help facilitate this include, can you think of any activities or hobbies that you used to enjoy doing but have now stopped doing? Can you think of any activities or hobbies that you would like to do but have never done? And it's important that these activities that are chosen are meaningful to the patient. Step 3 includes setting an action plan. So this involves shaping the chosen activity into a meaningful therapeutic goal. And the action plan allows for the specific goal to be obtained, defined in terms of observable and measurable characteristics. And it allows for the discussion of possible barriers as well to reaching the goal, as well as anything that can be addressed. And then it also includes possible facilitators of obtaining the goal, such as people or situations that might aid the patient. And step 4 includes monitoring progress and mood mastery and confidence. And this is best identified through homework assignments that ask the patient to document the frequency and use of the behavioral activity, and includes evaluating the action plan and the patient's ability to work towards achieving goals. And it's important that changes are made accordingly as well, in terms of the patient's needs. And this can show the importance of the exercise and serves to further motivate patients by increasing the effectiveness of the intervention. Module 12, problem solving. Problem solving involves steps for analyzing a problem, identifying options for coping, evaluating the options, deciding on a plan, and developing strategies for implementing the plan. Problem solving can also allow for increased control over issues for the patient, which and previously may have felt more overwhelming or unmanageable. And problem solving is especially effective when a specific problem is able to be addressed and operationalized, and it works best when a practical solution is available. Problem solving therapy, PST specifically, involves discussing the problem solving strategies that will be used during sessions. This can allow the patient to understand what they will be experiencing more better. And training should be tailored and specific to each patient, as every patient can have different needs. A thorough assessment of the problem should take place before beginning PST, and the patient should be encouraged to try as many solutions as possible. And it is important to assess whether the patient needs more problem-solving work or more emotional work. Problem-solving therapy also includes the SOLVED technique, which is an acronym, and the first letter signifies selecting a problem, which means asking the patient to think about situations when they feel distress or difficulty problem solving. And if planning does not seem to be possible, it can be helpful to suggest a different therapeutic technique. The second part includes opening your mind to all solutions. So it's important to be as broad as possible, and the patient should be encouraged to brainstorm all possible solutions. Therapists should ask the patient to think about advice they would give to someone else, and the patient should be asked to examine ways that they have handled similar situations in the past. The next step, or the part of the acronym, is listing the potential pros and cons of each potential solution. This allows for additional thoughts as well as a visual image of options, and patients should consider solutions in a logical manner. This may also require obtaining information from other people based on what the problem is, for example, lawyers or financial advisors. And the next step in the acronym is verifying the best solution. So this means examining the pros and cons list, and having the patient rank the solutions based on which are most practical or desirable for them. Next, we have enacting the plan, which means identifying the steps that are needed to carry out the selected solution. These steps may need to be broken down into smaller actions as well. Lastly, it includes deciding if the plan has worked. So this means following up with the patient and providing positive reinforcement if solution was effective. And if the solution was not effective, it may be helpful to return to the first step in the SOLVE technique in order to specify a new problem, or it can be helpful to identify other goals or potential solutions for the same problem. Module 13, relaxation. So relaxation techniques are psychotherapeutic techniques that are designed to reduce tension, stress, worry, and anxiety. And they vary in their focus and can be selected based on presenting difficulties and patient preferences. Relaxation techniques can increase self-efficacy, control over stress, and improve coping. Therapists should also create a safe, quiet, and comfortable environment as well before beginning any relaxation techniques. And in particular, 3 techniques include progressive muscle relaxation, deep breathing, and imagery. So progressive muscle relaxation, PMR, includes learning how to tense and then relax muscles groups in a sequential fashion while paying attention to the feelings associated with both tension and relaxation. And the patient learns how to recognize and pinpoint tension and relaxation in the body as well. And it includes 6 steps. So, step 1 is basically introducing PMR principles and procedures and signifying how PMR increases control. So the therapist can let the patient know that they can create sensations of relaxation, and that relaxation begins by being able to identify and discriminate between sensations of tension and relaxation. Step 2 includes noting the incongruence of tension and relaxation, which is simply explaining that sensations of tension and relaxation cannot occur at the same time. So a specific muscle cannot be tense and relaxed at the same time. Step 3 includes identifying states of tension. And it can be helpful to explain that tension builds gradually without conscious awareness. And it may be helpful to inform the patient that it's never too late to reduce tension, no matter how intense it may feel. And step 4 includes the actual work of tense muscle groups. And so PMR requires tensing and releasing different muscle groups in sequence, from the arms to the face, neck, chest, shoulders, torso, and leg. And it's important that in this step to ask the patient to describe bodily sensations. A question that can help with this is simply, what are you noticing about your body right now? And then step 5 includes a debrief after the exercise. So asking the patient about their reaction to the exercise and assessing any pain that the patient may have felt and making any needed adjustments. Some patients may experience pain with specific muscle groups. So it may be necessary to just, for those specific muscle groups, to just focus on relaxation. For step 6, continuing to practice outside of the session. So it's important for the patient to practice PMR at least once a day over the first week or 2 to build the skills and confidence. And the patient should practice in a non-distracting environment as well, in which they feel comfortable. And when the patient has learned to relax in a calm environment, it will also be easier for them to relax in a more distracting environment or situation as well. Another part of relaxation technique is deep breathing, which focuses on reducing rapid and shallow breathing that stress, worry, or anxiety may bring. And deep breathing can produce calmness by increasing oxygen-rich blood flow. And deep breathing can also strengthen muscles in the chest and stomach, which may make it easier to breathe on a daily basis as well. And the deep breathing promotes practice outside of the session, including homework assignments that encourage the deep breathing exercises during stressful situations. So a therapist can encourage this practice outside of the session as well, allowing for the patient to sort of have this in their toolbox in case they are experiencing any anxiety or stressful encounters. Next in relaxation techniques is guided imagery, which increases cognitive, emotional, and physical control by changing the focus of an individual's thoughts. It encourages positive adaptive dreaming, and it is highly effective for depression and anxiety and situations that require clarity, focus, distraction, or feelings of mastery. Guided imagery also uses the power of the brain to increase pleasant experiences. So there's a couple of steps that are involved in guided imagery as well. Step 1 can include, again, just introducing what guided imagery is and how images can change physical and emotional states for the patient. And then step 2 includes identifying desired outcomes such as decreased anxiety and increased focus. Step 3 includes selecting a powerful image or scene that the patient is able to fully embrace. And then step 4 is increasing the vividness of the image by exploring as many senses as possible. So if a patient is thinking of a scene in nature, it can be helpful to think about the sounds, the sight, the taste, the touch of that image itself. And step 5 includes asking the patient if they notice any changes, as well as for any general feedback. Step 6 includes repeating the exercise until the patient reports skill understanding and benefit. And then step 7 is asking the patient to identify situations in which imagery may be appropriate. This can allow them to use this again in their toolbox in a situation if they're feeling stressed out or anxious. And then step 8 includes continuing practice outside of sessions, including through homework assignments. Module 14, ending treatment and maintaining changes. So endotreatment planning is a collaborative process of preparing the patient to end treatment. It allows the patient to review learned skills and share any concerns about functioning outside of treatment. This actually begins in the first session when the frequency and duration of treatment is discussed. It's also important to discuss treatment termination in an empowering and thoughtful way, especially for patients that may have specific personality disorders or issues with abandonment. And some questions that can facilitate end of treatment planning can include: what have you learned as a result of our time together? Is there anything that was particularly meaningful to you about your time in therapy? This can allow the patient to reflect on all their sessions and sort of tie everything together that they have learned. Relapse prevention. It's important to anticipate any potential stressors and symptoms that can possibly create a relapse for the patient. It can be helpful to ask the patient what tools they have learned in therapy that could be used for particular stressors. When might the patient need to contact a mental health professional for additional assistance may also be an important topic to discuss. And it is also helpful discussing the preparation for inevitable difficulties, as this can empower and encourage the patient to be hopeful about their own skill sets that they have gained from the therapy sessions as well. Troubleshooting the end of treatment. So an entire session should be devoted to ending treatment, wrapping up, and maintaining changes without introducing any new concepts, as this can get overwhelming for a patient. The patient should also be given credit for all their progress. And this can also be an opportunity for the patient to discuss any concerns that they have had. And self-management time should also be encouraged by the therapist, which includes a few minutes each week to check mood and use skills to problem solve situations or feelings that may be negatively affecting mood. Lastly, booster sessions are also important. If the patient feels that they want to come back about a month after the end of the treatment, this can be helpful to check in, refresh skills, discuss any concerns, and as well review treatment goals. And that concludes the presentation. Thank you so much for listening.